everybody in the neuroscience tutorial question and answer episode number 5. Welcome back. Let's start with question number 1. The developing hindbrain rhombencephalon become organized in two segments designed R1 to R8 or RH1 to RH8 soon after closure of the neural tube. These are rhombomeres. Which of the following rhombomeres is associated with the location of the neurons that are developing in relation to facial nerve? A, R1 only, B, R2 plus R3, C, R4 plus R5, D, R6 plus R7, E, R8. Answer and explanation. This illustration shows the different vesicles of the primitive developing central nervous system or brain. This is rhombencephalon. Rhombencephalon or hindbrain, which differentiate into metencephalon and myelencephalon. Metencephalon will differentiate into pons and cerebellum. Myelencephalon will form medulla oblongata. This is the rostral caudal part is a spinal cord. This is the mesencephalon or midbrain will not differentiate to any part, still midbrain. Prosencephalon for brain will differentiate into telencephalon and diencephalon. So in the answer, the correct answer is C. Rhombomeres are 4 plus 5. The hindbrain can be subdivided into variable number of the transverse swelling called rhombomere. In the human embryo, each rhombomeres can be distinguished from caudal to rostral, RHA to RH1. Rostrally, the isthmus demarcates the boundary with the midbrain. Rhombomeres R3 to R1 form the metencephalon. The metencephalon is composed of pons and cerebellum. Rhombomeres R8 to R4 form the myelencephalon. So metencephalon or pons and cerebellum formed from only 3 RH3 to RH1. Only 3 rhombomeres, but the myelencephalon, which form medulla oblongata, formed from 5 rhombomeres. Neurons that well associated with the facial nerve, which is cranial nerve number 7, develop in relation to rhombomeres are H4 to RH5, with the root of the nerve lying at the level of RH4. Rhombomeres RH1 is related to neurons of the trochlear nerve, which is the cranial nerve number 4. RH2 to RH3 to trigeminal nerve, which is the cranial nerve number 5. And this is important landmark because 2 plus 3 equal 5. And the trigeminal nerve is the cranial nerve number 5. So take it as a very important landmark to remember, or pneumatic to remember before it is the trochlear nerve, which is 4 and formed from RH number 1, and the following portion are H number 6 and RH number 7 or RH number number 4 and number 5 will form the following cranial nerve, which is 7th cranial nerve, don't-occlusive cranial nerve, which is related to the eye, or abducent nerve, which is specifically to lateral recti muscle, or 9th cranial nerve, which is a special sense cranial nerve. So you can remember this categories or this number by this pneumatic RH2 plus RH3. 2 plus 3 is 5, so trigeminal or 5th cranial nerve is formed from RH2 plus RH3. Question number 2. The MRI of the 4-day-old female newborn reveals cerebral hemispheres that have some large broad gyri interspersed with areas containing very small irregular gyri. These are pachygyria and microglia respectively. Which of the following events during pregnancy could explain this outcome in this baby? Agenesis of the corpus callosum, B, dietary deficiency of the vitamin A, C, failure of the microglia to invasiveness, D, high intake of the dietary folic acid, A, improper neural migration. Answer and explanation. The correct answer is A, improper neural migration, which is called neuronal migration disorder, or NMD. Neuronal migration disorder is improper neural migration. Refers to heterogeneous group of disorders that share the same etiological mechanism, which include a variable degree of disruption in the migration of the neuroblast during neurogenesis. So, the neural migration disorder are cerebral dysgenesis or brain malformation caused by primary alteration during neurogenesis. Variations from the normal pattern of the cortical gyri and sulci reflect this abnormal pattern of the neural migration on radial glia. In case of the microgyria, there is exuberant migration and smaller gyri, so more numerous patterns are created. In the case of the pachygyria, migration is slow and apparent with creation of the fewer larger gyri. More than 25 syndromes resulting from abnormal neural migration have been described. Among them are syndromes with several different patterns of the inheritance. Genetic counseling thus differs greatly between syndromes. These syndromes include lissencephaly, microlissencephaly, schizencephaly, borencephaly, pachygyria, polymicrogyria, ageria, macrogyria, micropolygyria, and neuronal heterotopias, agenesis of the corpus callosum, agenesis of the cranial nerves, band heterotopia, focal cortical path, focal cortical dysplasia, Miller-Ticker syndrome, muscle brain eye syndrome or disease, Fukuyama, congenital muscular dystrophy, and Walker-Wahlberg syndrome are genetic disorder associated with lissencephaly. And this is important point. Agenesis of the corpus callosum is sometimes seen in individuals with no frank neurological deficit, may be completely normal, and discovered accidentally during conduct MRI or CT. The fibers that would otherwise form the corpus callosum become longitudinally oriented along the ipsilateral ventricular wall and form structure called propest bundles. So it is become longitudinally, and the original is transversely connecting between right and left hemisphere. Signs and symptoms of the agenesis of the corpus callosum and the other callosal disorder vary greatly among individuals. However, some characteristics common in individuals with callosal disorder include vision impairments, low muscle tone, hypotonia, poor motor coordination, delays in the motor milestones. In addition to agenesis of the corpus callosum, other callosal disorders include hypogenesis, partial agenesis, usually referring to the lens, or dysgenesis, malformation, referred to the shape, and hypoplasia, underdevelopment, usually referring to the thickness of the corpus callosum. So, hypogenesis referred to the lens, dysgenesis referring to the shape, hypoplasia referring to the thickness of the corpus callosum. Primary vitamin A deficiency occurs among children and adults who don't consume an adequate intake of the provitamin A, carotenoids from fruits and vegetables, or preformed vitamin A from animal and dietary products. Secondary vitamin A deficiency is associated with chronic malabsorption of the lipids because vitamin A is fat-soluble vitamins. So affected by chronic malabsorption of lipids or impairment bile production, which is responsible for bile absorption, fat absorption and release, and chronic exposure to oxidants such as cigarette smoke and chronic alcoholism. High level of the folic acid have no untoward effects and may even protect against dystrophic defects. Folic acid acts by helping the body produce and maintain new cells. In particular, red blood cells formation is dependent upon adequate levels of this vitamin. Low levels in early pregnancy are believed to be the cause of more than half of babies born with neural tube defects. More than half may reach 2 to 70% of the defects. Microglia Microglia invade CNS at the same time as blood vessels. Failure in this process would most likely correlate with apparent blood vessels development. For a long time, it was thought that microglial cells differentiate into the bone marrow from heterotopic hematopoietic stem cells, which is the progenitor of all blood vessels. However, recent studies show that microglia originate in the yolk sac during remarkably restricted embryonal period and populate the brain mesenchyme. Additionally, they continuously renew themselves and persist throughout life without replacement from peripheral monocytic precursor. So it is completely separated and completely independent from hematopoietic cells because it's present throughout without replacement from the peripheral monocytic precursor. Like macrophage in the rest of the body, microglia use phagocytic and cytotoxic mechanisms to destroy foreign materials. So it's important in the immune system of CNS. Microglia and the macrophage both contribute to the immune response by acting as antigen-presenting cells. Question number 3. A 7-year-old girl is brought to pediatrician by her mother. The girl thinks that there is something wrong with her eyes because she is having a lot of trouble playing goalie on her soccer team. Goalie or goalkeeper. Testing, which include ophthalmoscopic examination, reveals that vision in her right eye is essentially normal, but when her right eye is covered, visual acuity is extremely low. In the left eye, depth perception is almost non-existent, and she is unable to perceive shapes in the random dot stereogram. Which of the following is likely cause of this problem in this girl? Amblyopia, B. Cataract, C. Myopia, D. Nyctalopia, E. Presbyopia. Answer and explanation. The correct answer is A. Amblyopia. Amblyopia, which also known as lazy eye, is a developmental condition that results when incoming visual information from the eye is basically ignored by the visual cortex because of wiring problem within the cortex. If discovered early, it can be treated with wearing a patch over the good eye to force the visual projection mediated through the good eye to remodel up to and including the visual cortex. This figure illustrates the amblyopic curve. We cover the good eye and expose the affected eye. So this is the good eye. Amblyopia begins during infancy and early childhood. In most cases, only one eye is affected, but in some cases, reduced visual acuity can occur in both eyes. Particularly if lazy eye is detected early in life and promptly treated, reduced vision can be avoided. But if left untreated, lazy eye can cause severe visual disability in the affected eye, including legal blindness. When amblyopia affects both eyes, it is so difficult to becomes so difficult to treat it. But cataract, opacity of the lens, often develop slowly and they can affect one or more or both eyes. Myopia, nearsightedness, and presbyopia, loss of accommodation, are also visual problems that are almost exclusively seen in much older patients. And this is important differentiating point according to the type of the patient or age of patient. Nyctalopia is lessened ability to see in reduced illumination. This may be seen in vitamin A deficiency since this type of vision is a function of the rods. Question number 4. The correct orientation of the purkinje cell dendrites in the adult cerebellum is dependent on the orientation and developmental patterns of which of the following: A. Climbing fiber, B. Golgi cells, C. Granule cells, D. Mossy fibers, E. oligodendrocytes. Answer and explanation. The correct answer is C. Granule cells. The precursor of the granule cell differentiate in the external germinal layer of the early cerebellar anlage, the rudimentary basis of the particular organ in the embryo. This is anlage. At the same time, precursors of the purkinje cells are proliferating in the internal germinal layer of the ventricular zone. The developing cells that will become the purkinje cells migrate outward on radial glial to take their position in the molecular layer, while the precursor of the granule cells migrate inward on radial glial. These are the Bergman fibers, Golgi epithelial cells of the adult, to take up their positions in the granule layer. As the dendritic tree of the purkinje cells grew outward, it encountered the inwardly migrating granule cells. Axonal sprouts of the granule cells encounter the Purkinje cells dendrites and make primitive synaptic contacts. As the migration of the granule cell proceeds, these axonal processes are enlarged due to their opposition to the dendrites of the Purkinje cells, and the granule cells continue inward to reach the granule layer where it sprouts its short dendrites. These two patterns are intimately related one to the other. Climbing and the mossy fiber establish their synaptic relationship later. Golgi cells arise from the internal germinal layer. Oligodendrocytes or glial element which is responsible for formation of myelin sheath inside central nervous system. The function of Schwann cells in the peripheral nervous system. So, two types of the neuron play dominant roles in the cerebellar circuit, Purkinje cells and granule cells. Three types of axon also play dominant roles, mossy fibers and the climbing fiber which enter cerebellum from the outside, mossy and climbing, and parallel fibers which are the axon of the granule cells. These figures illustrate what we said. This is a Purkinje cells. This is a Purkinje cells, and this is a Golgi cells. This is granule cells, which is pink in color. Granule cells, mossy fiber terminal with granule cells. This is mossy fiber coming from bones and mid-brain and spine, midbrain. Climbing fiber from oliva inferior. This is input, this is input. But this is Purkinje cells, glutamatergic, which is stimulative fiber. Stimulator fiber is the mossy fiber and the granule fiber. GABAergic cells, which is inhibitory cells, includes Purkinje cells mainly, and stellate cells. Parallel fiber is the continuation of the or axons of the granule cells. It's also stimulatory. It's granule cells, it's Golgi cells, Purkinje cell layer, molecular layer, this outer part molecular layer, this Purkinje cell layer. This is Bergman-Golgi cells. In this figure, this is heterosynaptic interaction. This is parallel fiber of the granule cells. This is mossy fiber, synaptic with granule cells. This is climbing fiber. This is Purkinje cells. This is output. This is input. This is input. It's climbing cells. Look, it's climbing cells. Heterosynaptic interaction between parallel fiber of the granule cells and the climbing and Purkinje cells. There is a parallel fiber Purkinje cell synapses, parallel fiber and the Purkinje cell synapses, it's basket cells, it's Purkinje fibers, the menin inhibitory fiber in the cerebellum, the granule cells, it's mossy fiber, it's climbing fiber. So this climbing is very important and very apparent in this, and very obvious in this image. Climbing fiber, deep cerebellar nuclei neuron. This is deep, this is interior, and this is exterior or the outer surface. So this is outer surface, there is outer surface, and this is the inner surface. Question number 5. A 3-day-old female baby presents with a small pigmented area at the midline on her lower back. Close examination reveals a small tuft of delicate hair associated with a small cutaneous dimple. Clear fluid issues from what appears to be small opening in the dimple when palpated. Which of the following most closely signifies these defects? Encephalocele, spina bifida aperta, spina bifida cystica, myeloscasis, spina bifida occulta. Answer and explanation. The correct answer is A, spina bifida occulta. Neural tube defects may occur rostrally, where the anterior neuropore anencephaly or caudally, where the posterior neuropore closes spina bifida in its several forms. In spina bifida occulta, the skin is essentially closed, but there may be cutaneous evidence of the defect, such as pigmentation, ridge spot, hair tufts, dimple, or possibly dermal sinus tract. In spina bifida aperta, the skin is not closed over the defect. As the name implies, spina bifida cystica is characterized by sac-like deformations that may contain only meninges and cerebrospinal fluid (CSF), meningocele, i.e. meningocele because it is formed of meninges and cerebrospinal fluid, or meninges, CSF, meninges, CSF, and spinal cord, meningomyelocele. Meningo refer to meninges, myelo refer to spinal cord, cele refer to tumor or swelling. Myeloschisis, the myeloschisis or rhombomeres is the severest form of spina bifida aperta. The nerve tissue is here fully bare, and a dermal or meningeal covering is absent. With this abnormality, the closure of the neural fold failed to occur completely. Encephalocele is just like a meningocele, but associated with the head, occipital or frontal region. Question number 6. A male baby is born with saccular structure approximately 6 cm in diameter located in the lumbosacral region. As one step in the assessment of the possible treatment options, CT and MRI are conducted to clarify the poor relationships and soft tissue contents of this lesion. These images reveal that the structures contain fluid, portion of spinal cord, and nerve roots. Which of the following would most correctly describe this lesion? Encephalocele, meningocele, meningoencephalocele, meningomyelocele, spinal bifida occulta. Answer and explanation. The correct answer is D, meningomyelocele. This structure contains meninges, cerebrospinal fluid, and internal structure, hence its meningomyelocele. A hernia or tumor cell containing spinal cord, myelo, and meninges. Almost all of this saccular lesion contain at least meninges and CSF. The addition of the portion of spinal cord increases the level of complexity and treatment. An encephalocele or meningoencephalocele are quite similar. The encephalocele is described as a cranial defect, bifidum cranium, with herniation of the brain, but not necessarily also containing the meninges. The meningoencephalocele is a defect in the skull with extrusion of the meninges and the brain throughout the defect. Meningocele is a spinal defect. Agenesis most likely in the occur most likely in the lumbosacral area, consisting of sac containing only meninges and CSF. While spina bifida occulta has no associated saccular structure, spina bifida occulta is the malformation of one or more vertebrae. It is sometimes called closed spina bifida. In most cases, spina bifida occulta causes no problems. Question number 7. The sonogram of the 23-year-old pregnant woman 2 months prior to term reveals that her fetus has a growth or defect in the frontal area of the skull. The history reveals that the woman has a freewheeling lifestyle and has not been attentive to proper diet. including regularly taking hair vitamin supplements. Vitamin supplements. The child is born with large masses on the forehead, partially cleft nose, and ocular hypertelorism. CT and MRI on D3 reveals a defect in the frontal bone and a mass containing fluid portion of the frontal bone and a cavity that is continuous with anterior horn of the lateral ventricle. Which of the following is specifically descriptive of this defect? Meningocele, meningoencephalocele, meningohydroencephalocele, meningomyelocele, microencephaly. Answer and explanation. The correct answer is C, meningohydroencephalocele. This lesion is a frontal encephalocele that, based on its structure, is meningohydroencephalocele. Like meningoceles, meningohydroencephalocele is caused by defect in bone ossification. In the particular, the intramembranous ossification related to the closure of the infantile fontanelles. It refers to protrusion of the meninges between the unfused bones subcutaneously. Meningocele refers to herniation of meninges. Meningoencephalocele refers to the condition of the brain tissues is included with the meninges in herniation. Meningohydroencephalocele refers to the condition including meninges, brain tissue, and part of the ventricular system in the herniation. And this is our case in this question. This is meningoencephalocele. This sac contains meninges, part of the brain. This is meningoencephalocele. But during meningohydroencephalocele, this part of the lateral ventricle is included in this swelling or in this herniated part of brain. This is exoencephaly. Most of the brain is present outside of skull, like this. Microcephaly is a medical condition in which the brain doesn't develop properly, resulting in a smaller than normal head. Microcephaly may be present at birth, or it may develop in the first few years of life. Often, people with the disorder have an intellectual disability, poor motor function, poor speech, abnormal facial features, seizures, and dwarfism. Again, intellectual disability, poor motor function, poor speech, facial features, abnormalities, seizures, and dwarfism. The disorder may stem from a wide variety of the conditions that cause abnormal growth of the brain or from syndrome associated with chromosomal abnormalities. Chromosomal abnormalities is an important point. A homogeneous mutation in one of the microcephalin genes causes primary microcephaly. It is usually defined as a head circumference, HC, more than 2 or 3. It is controversial at this point. 2 or 3 standard deviation, but mainly 2 standard deviation below the mean for age and sex. Question number 8. A 34-year-old mother from a poor rural country gives birth to a male child. Based on her circumstances, she sought almost no perinatal care, visiting a physician only once when she first thought she was pregnant. This child is born with catastrophic developmental defects associated with a failure of the anterior neuropore to close. Which of the following most specifically designates the developmental failure? Anencephaly, dermal sinus, encephaly, meningocele, meningomyelitis. Answer and explanation. The correct answer is A, anencephaly. The lamina terminalis of the adult is a structure representing the general location of the closed anterior neuropore. Failure of the anterior neuropore to close anencephaly results in combination of profound defect. Most of the forebrain is absent or severely malformed. The calvaria, which is skull, is largely missing, and there are associated facial abnormalities. Anencephaly is seen in 0.03% to 0.070% of the births. Most of them occur in the female with history of the neural tube malformation. Affected infants are usually stillborn or die within a few days. very few many survive for 2 to 3 months. Studies have shown that the condition of the folic acid to diet, the addition of the folic acid to diet of the woman of childbearing age may significantly reduce, also not eliminate, the incidence of the neural tube defects. So it is so important. This figure illustrates what we said about. This is normal brain. This is abnormal but not related to anencephaly. This anencephaly, but it is in French language. Congenital dermal sinus is scaly, multi-layered channel of tissue found along the body's midline anywhere between the nasal bridge and the tailbone. The tract may end just below skin surface or may extend to portion of the spinal cord, skull base, or nasal cavity. Sinuses above lumbosacral region should be surgically removed because it may lead to severe problems. Although approximately 25% of the presumed sacral sinuses seen at birth will regress to a deep dimple on follow-up. Although of this, all dermal sinuses should be surgically explored and treated prior to the development of the neurological symptoms or sign of infection. The results of the treatment following intradural infection are never as good as when undertaken prior to infection. Question number 9. A 26-year-old woman gives birth to a male child with spina bifida and bifidum cranium. The mother's nutritional status and general health are unremarkable. She has been taking multivitamin supplements daily since her teens, and there is no evidence of the drug use or family history of the developmental defects. The only significant features of the mother's medical history is that she is an epileptic and is on long-term therapy to generalized seizure disorder. Given these facts, which of the following is the most likely cause of this childbirth defects? Hypertension, ingestion of the folic acid, number B. C, ingestion of the vitamin D. D, vitamin C toxicity. E, valproate toxicity. Answer and explanation. The correct answer is A, valproate toxicity. Anti-seizure medication, valproate and the carbamazepine, among others, can cause dystrophic defects. This is thought an interference with the folding process of the neural tube. Women with epilepsy who take valproic acid during the first trimester of pregnancy are more likely to have children with birth defects than women who took other epilepsy drugs or no medicine to control their seizure during pregnancy. Valproic acid is also used to treat other illnesses, including bipolar disorder and migraines. Since switching drugs during or just before pregnancy is difficult, the risks associated with valproic acid use should be routinely considered in choosing therapy for women with childbearing potential. Sex birth defects were more common among children of women who took valproic acid during the first trimester than children of women who didn't take anti-seizure drugs. Spina bifida, atrial septal defects, cleft palate, hypospadias, polydactyly, extra finger or toes, craniosynostosis, one or more sutures on the baby's skull close prematurely. When compared with other epilepsy drugs, valproic acid increased the risk for all of these birth defects except craniosynostosis. The study showed that it also showed an increased risk of ventricular septal defect when compared to other epilepsy drugs. Hypertension in this question is not mentioned in this woman's case and has not been associated with developmental defects in general, even it mentioned in this question. Ingestion of folic acid and vitamin D is actually good, since supplemental doses of the folic acid are associated with prevention of dystrophic defects, which is a specific congenital problem of valproic acid, especially with the patient of the known risk. So, like or such as women which take valproic acid to control seizures. This is some types of toxicity of the valproic acid may lead to alopecia, thrombocytopenia, hepatotoxicity, pancreatitis. Question number 10. A failure of cell migration during development of the central nervous system may result in minor defects that result in little or no defects, or may result in catastrophic defects that are not compatible with life. Thus, successful migration of the developing neuron is absolutely essential in the creation of the normal nervous system. Which of the following is a necessary element in success of this process? Fibrous astroglia, B. Microglia, C. Oligodendroglia, D. Protoplasmic astroglia, A. Radial glia. Answer the explanation. The correct answer is A. Radial glial. Cell body of the radial glial are located near the luminal surface of the developing neural tube, and their apical process extended to abdominal surface, which is the external surface of the developing embryo. In this respect, the radial glia are unique in that their process extends the entire width of the developing neural tube, and by doing so, they migrate from their origin in the ventricular zone to their final location. Radial glial are also the first glial cells to appear, since they are essential for future stages of the development. Radial glial cells are bipolar shaped cells that span the width of the cortex in the developing central nervous system, as said before, and serves as primary progenitor cells capable of generating neurons, astrocytes, oligodendrocytes. Most radial glials have restricted unipotent or multipotent fates. Radial glial cells originate from transformation of the neuroepithelial cells that form the neural plate during the early phases of the prenatal neurogenesis. All other glial cells appear at later stage. But don't forget, microglial is not originated from radial glial cells. This figure to what we said. This is a radial glial. This is ventricular zone or internal zone, and this is cortical plate or external surface. This is ganglion eminence. Fibrous astroglia, fibrillary astroglia, and oligodendrocytes are found predominantly in white matter, and protoplasmic astroglia, astrocytes are found mainly in the gray matter. And this is logic. Fibrous is formed of fiber, so it's presented in white matter. Oligodendrocytes is responsible for formation of the myelin sheath and central nervous system, which is white in color, so it is important and it is presented in the white matter. But protoplasmic astroglia, from its name, is protoplasmic, so it is present in gray matter. Studies have found that the astrocytes proportion varies by region and ranges from 20% to 40% of all glia. Astrocytes propagate intercellular calcium waves over long distance in response to stimulation, and similar to neurons, release transmitters called gliotransmitters in calcium-dependent manner. This figure shows the different central nervous system cells. This is astroglia, it's related to blood vessels. This is astrocytes or astroglia. This is neurons, which has axon covered by myelin sheath, which is formed by oligodendrocytes. Oligodendrocytes form myelin sheath in central nervous system, so it is oligodendrocytes. This is myelinated axons, and this is microglia. It has no relations to axon or myelin sheath. It's related to immune system. It is ependymal cells, cerebrospinal fluid. It's prevascular fate of the astrocytes. So astrocytes has prevascular fate and has fate on the neurons itself. feeds on the neurons, feeds on the blood vessels. So it's had multiple and versatile character of the function. Time to say goodbye. Goodbye. Thanks.